Welcome back, everybody. This is registered dietitian Myrna Haag. Welcome to the Myrna Method. I try to bring you impactful information on health that nutrition can make a huge difference. What we're going to talk about in this video is a marker called the lipoB, the lipoprotein B, APOB. And this is a marker you can get in your standard lipid panel. When you go to your doctor and you're getting your cholesterol checked, you can ask for this marker. Super important. In fact, if you could only get one marker, this would be the one to get. It's that significant. And the amount of information it tells you is mind-blowing. And why is that? Because there's a lot of things that they're not measuring that this APOB marker tells us will put you at greater risk for heart attack and stroke. What I'm also going to tell you in this video is how to significantly reduce that APOB marker if it is elevated. I'm going to show you some patient laboratory reports and let you see patients on medications, patients not on medications, and how the APOB is affected. So Sam, if you'll switch it over, let's get right into the PowerPoint. All right. So this is a test I think all doctors should be doing. Super easy test. And it's also one of the tests you don't even have to fast for. Although in a typical lipid panel you do. So let's get right into it and find out what makes the APOB, lipoprotein B, so amazing and why everybody needs to get the test. So what is the APOB? The APOB is the lipid, which just means fat, protein carrier. So it's just these little, I guess, vessels, you could call them, that carry around the fat through the body. And in this particular protein carrier, it carries all the bad cholesterols. Now, when you go and get your labs, they're only going to be looking at the LDL, and they're not even going to give you the full information on the LDL, because LDL can also be distinguished by particle sizes, particle number. So this is important to understand that there's more information that will greatly impact whether you're going to be at risk for heart disease. So in this particular carrier, it does two things, two ways it damages the body if you are elevated. So if your APOB is elevated, it can create more plaque inside the artery wall, and it can cause lesions on the artery wall. Not so good to have lesions, because lesions can cause rupture, which that can then lead to a heart attack or stroke. So the standard cholesterol panel only measures the LDL concentrate. So this is the only one right here that they're measuring, and we have all these others that the APOE is carrying, and all these other fats are very much part of the plaque that forms in your artery. So when we look at the APOB, we're looking at the atherogenic fats, and that means the fats that literally build up this artery. They create this waxy substance that then can harden, that's the calcified plaque, and can narrow these arteries, restricting blood, restricting oxygen flow to super important areas of the body. So the main ones that we look at are the triglyceride remnants. So you have elevated triglycerides, you're going to have more triglyceride remnants, VLDL, LDL, and lipo-a. Lipo-a is a gene. A lot of people don't know they have it. I did a podcast on it. That's another marker you can get, gene marker. The LDL comes in certain sizes and certain amount of particles. So when we look at our lab, typical lab values, it doesn't give us enough information. So that APOB is all you need, because if this is elevated, we know you're going to probably have a lot of LDL particles. They may be smaller, and you might even have the be a genetic carrier for the lipo-a. So by getting the APOB, we may not even need to get these other tests. So when we look at what exactly is going on with the APOB, think of it, I kind of think of it as the taxi driver or the bus driver that's carrying all the bad fats. So this is the lipid carrier that carries the LDL, VLDL, triglyceride remnants, lipo-a. These guys all hop on that bus and they go through the arteries and they literally can get into that wall because they travel through the lumen, they get in that wall and they get very sticky, especially if you have a lot of them. They don't really get out of the wall. What they do is they create inflammation in the wall. And this is what happens with heart disease. We get this inflammation, which then triggers an immune response. So when we look at heart disease, these fats become oxidized, and this means that they're being acted upon by certain chemicals, and this creates an immune response. So you're going to get an immune cell, a macrophage, which is going to go over to that location, and it's going to lay down a plaque. It's going to lay down what's called a foam cell, and then that hardens and it becomes calcified. And the more and more of that we have, the narrower and narrower that artery wall becomes as this plaque calcifies. So the beginning agent, where it all starts, is with the APOB marker, carrying these fats to the wall and creating this oxidation and inflammation. So the macrophages, those are the immune cells these are the main ones responsible for that whole escapade. So bottom line, why this is super important is that it literally causes this vascular inflammation. A lot of people don't even know they have. Why it's important to get that APOB is because you want to know the level at risk you're at, and you may not know looking at your lipid panel. So when you have this plaque, which is going to show up in the APOB test, this is going to tell us that you're going to have an increase, and a lot of people can have an increase in blood pressure. Well, that makes sense because the arteries narrow. It's going to disrupt the vascular flow of blood, and that's the huge one, because this can lead to dementia, can lead to more heart disease. It can cause legs and arms to have restrictive blood flow. That's where we see a lot of times people have to have stents, right? Because they have to open up those arteries. But the worst part and the most damaging and really the most dangerous is the plaque rupture, because these fats can also go in there and cause damage on that artery wall. And this can cause a rupture of the plaque that's inside the wall. This is when pieces break off. It's like creating a huge traffic jam in your artery. So imagine if a piece of this breaks off. We already have a narrow artery wall because of all the plaque. All it takes is that to just clog up that area, and there you go. That's where you're going to get the stroke, because you're not going to be able to get the blood to the heart. It's not going to get the oxygen, and this is going to be what we're going to see when somebody has a heart attack. Not something we get warning about, and that's the thing with heart attacks. You don't really get a warning. Sometimes the only warning you get is when it's too late. What we do is we get our lipid panel done. We get blood tests to decide how close we are to this risk factor. And the blood tests are supposed to tell us where we are on that spectrum in risk. When you're looking at dementia, and I think this is really important to think about, because dementia, some of the main causes of Alzheimer's and dementia can be a sugar problem, and I talked about that at type 3 diabetes. But even with type 3 diabetes, it all comes down to a fat toxicity. When I'm looking at dementia because of plaque buildup, what did I say plaque was? Fat. A lot of bad fats, but again, it's fat toxicity in the body. And where do a lot of these fats come from? From being too fat, right? So when you have a lot of excess fat, obesity, a lot of these fats get released into the bloodstream, or eating too many dietary fats can also contribute to this. So this plaque buildup is going to cause a problem because it really narrows the artery and it reduces the supply of blood. This is where it causes a problem in cognitive decline. It disrupts oxygen and blood flow to the brain, and it also damages brain cells, and you don't get those back. So brain cell death, it's because it's reduced from blood flow. It decreases oxygen and nutrients to brain cells, which then, of course, that's where you get the neuronal cell death. So this is according to the National Institute of Neurological Disorders and Stroke, and they talk about cerebral arteriosclerosis, and that again is just plaque buildup. So cerebral arteriosclerosis is a disease that occurs when the arteries in the brain become hard, thick, and narrow due to the buildup of plaque, which are the fatty deposits inside the artery walls. This buildup decreases the amount of blood flow to certain areas of the brain. If the buildup becomes too severe, it can block flow and cause a stroke and can permanently impair the brain and body functions. It can also result in aneurysms. So this is all about this plaque buildup and understanding how you know you're at risk, because you don't know walking around. You can feel fine and have a problem, a risk for cardiovascular disease. So to me, this APOB is one of the best markers that you can get. It'll give you more information because it's going to tell you, and I'll come back to we'll talk about peripheral artery disease. And this is, of course, when we're blocking that blood flow to the arms and legs, the extremities. Okay, so PAD, peripheral artery disease, is an accumulation of plaque in the arteries in your legs and arms. This makes it harder for your blood flow to carry oxygen, nutrients to the tissue in those areas. So let's look at a lipid panel so we can kind of see what we're talking about here. So when we typically look at a lipid panel, we're going to be looking over at this side of my screen. So the part I'm circling shows the typical cholesterol, your HDL, which are the good cholesterols, your triglycerides, your LDL, and then they do a ratio to tell you your risk, which is this non-HDL cholesterol. Bottom line, what they're looking at to determine your cardiovascular risk is going to be your cholesterol, your HDL, your LDL, your triglycerides, and then the ratio among those to see how at risk that is. So here's a patient, a male, 72 years old. He's already had stents in his legs, so he's already had some peripheral artery disease. He's 45 pounds overweight, and for a lot of males, they don't consider that really even overweight, right? Just a little belly on me. And he exercises 4 times a week, about an hour and a half. So he is an exerciser. He goes to the gym regularly. He's on medications. He's on statins. And he's also following a Mediterranean diet. And I'm going to talk about that because everybody says, well, if you're on a Mediterranean diet, isn't that the gold standard? Not really. Because the Mediterranean diet, just like a lipid panel, is not giving you enough information. So the Mediterranean diet is fine for some of the foods that are in the Mediterranean diet, but what you got to look at, is it a Mediterranean diet that's low in fat, low in carbs, high in fat? A lot of people say, well, I eat healthy, but that's not the ticket. You got to look at those macronutrients. And specifically, the two that make the biggest difference is going to be an increase in fibers and a decrease in some of these fats. Now, you need healthy fats. And a lot of people are so confused exactly how much fat they do need. So we're going to go over that in this video like I do in so many of my other videos. So let's go back to this blood panel. So typically a doctor would look at this and say, wow, you're doing terrific. Wow, isn't this wonderful? Now this patient is on statins, and I have plenty of patients that are on statins that get heart attacks. Yep, that's right. He's got it down to 129 for his cholesterol. We want it under 200. So by most standards, I don't know anybody who can get it under 129 unless they're on medications. So this guy's taking medications so he can get this terrific blood panel and his LDL, which are the damaging fats. Those are the ones that everybody looks at as being the big oxidizers. Those are the ones that create the plaque when they typically look at your lipid panel. The HDLs are the good cholesterols, and they typically go and clean up the bad guys. So they look at a ratio to see how many bad guys and good guys you have. And if you have enough good guys, they say, don't worry about the bad guys. But that's not true. Absolutely does not give you the full picture of your risk. So in this case, we want to have your LDLs under 100, and this gentleman has it at 67. Like I said, a doctor would look at this and say you're great. But now let's go look and see how many particles are in the LDL, because the labs only tell us the concentration. If I go to this side of his blood panel, I'm going to see that he's in the red. We want to have less than 467 particles of LDL, and this guy's got almost 3 times that. He has got a lot of particles because they're smaller. So LDL comes in sizes, and your typical lipid panel doesn't tell you that. Well, in this case, we can see he's got a lot of small little guys, which is going to make those LDL fats even stickier, okay? Also, we're going to look at his VLDL, which was another carrier on that APO bus. He is not a gene carrier for the lipo-a, but when I look at his APOB, he's at 88. Now, we're going to look at that number because a lot of tests will tell you, well, as long as you're under 90, you're okay. But actually, when you look at a lot of the reports with these cardiologists, they're saying not necessarily. If we're looking at somebody that has had a cardiac event, they've had a heart attack, stroke, or they have stents, which means they've got a lot of narrowing. If they're already putting stents in your artery, that's where they're literally trying to open up that artery to let that blood flow. So a stent is where they go in surgically and just try to pry that thing open and put a little device that hopefully will keep it open. But in this case, we want somebody to have their APOB under 60 if they've had an event. Now, if they're over the age of 65 and they have some calcium, which means they're going to show an elevated calcium score, calcium deposits, okay? So that's what that calcium score is. It's when that plaque becomes hardened, it becomes calcified, and we can get a score. So let's say you have an elevated calcium score, meaning you have some narrowing of the arteries. You've got diabetes, which already means you have a fat toxicity. You have hypertension, you have obesity, and your lipid panel is elevated, and that's not even getting the APOB. So we're going to try to keep that APOB under 70 milligrams per DL. Now, if you're under 60, fairly healthy, if you keep your APOB, according to studies, 80 or less, you're going to have a much, much lower heart disease for the remainder of your life. So we want to try to get a lot of young people to be watching out for this APOB, because we don't want it to be elevated most of your life, and then you come see me as a clinical dietitian, and I'm going to try to get you on a diet to reverse it. But what I'm going to probably have to do is give you a more conservative diet, right? Because I'm trying to already get you down from some damage you've already created. Typically, medications are giving for APOBs that are going to be 100 milligrams per DL. Typically is when I see a lot of concierge doctors, the guys that I work with, cardiologists, this is when they really start to decide maybe you need to get the medication. What they're looking at when they do that is not just a lipid panel that the typical doctors are going to look at. They're going to look at some of this other information. Now, with this patient of mine, he's on meds, and he already has an APOB of 88 on meds. And the reason why is because although he thinks he's eating healthy, and he's under this false feeling, as long as he's on medications, he's going to be fine, because he's looking over on this side of his panel, but he's doing a diet that's not high in fiber. He's doing a low-carb diet because he's got some insulin resistance, pre-diabetes, and he's been told that he should be really taking those carbs to a lower level. which I have some podcasts where I talk about type 2 diabetes, and carbs need to be managed, but it's really the fat that's the problem. A lot of this excess fat that we're eating, excess body fat. But bottom line, if we work on his diet, right, we can lower that APOB. This APOB is, even though his cholesterols are low, why this APO isn't below 60 is because he's got a lot of small ones and he's got many particles, okay? Which, like I said, we wouldn't know it on this panel. And if we're trying to reduce his risk, when I did his panel and I looked at it, I just said, hey, listen, you are at risk because you've had the stents. You've got some work to do. Although this may look great to you, we need to try to get that APOB lower. And that's what a diet can do, because the medications are already doing their part, right? So a lot of people don't understand. They look at their lipid panel, they think it's great because they're on meds, but you have to bring the diet in if you want to get some of these things on the other side low as well. So let's look at another patient. This is a female. She's 62 years old. She's not on any medications. She's at her ideal body weight of 120 pounds. She's also on the Mediterranean diet. Her fats on the Mediterranean diet are anywhere from 35 to 40%. When I look at this other patient, his fats are over 50. So he's got a diet of over 50% fat, which I'm going to show you isn't even a lot of fat, but I'm going to explain to you how you know how to interpret that for your own plate, right? Because 50% fat doesn't mean anything to you. If I just tell you right now, you're like, okay, what does that mean? 50% of my plate? Nope, there is a gram, and we'll go over it and what exactly that means. In this case, with this patient, she exercises every day. She's an avid exerciser, no medications, and now let's look at her lipid panel. Well, her cholesterol is just one mark over 200. Most people wouldn't really bat an eye at that. She's at 201. We want your total cholesterol under 200. Her HDLs are really high. They're 74. That's because she's exercising 7 times a week. And for a female, we want them over 50. She's at 74. Terrific, terrific. Her triglycerides are 52. They're low. We want her triglycerides under 150. But her LDL is 114. We want her LDL under 100. And all her ratios are fantastic. So most docs would say, we're not going to worry about that LDL. They may not even worry about that cholesterol because they would look at the ratios of the good to the bad cholesterols, the cholesterol to the HDL. When they look at that, they're going to say, wow, you're under 3.5. You've got great ratios. And when she came to me, that's exactly what she said. I have great ratios. Even though I'm a little elevated in some of those atherogenic fats, those plaque-forming fats, I'm still fine. So we did some more tests, and here's what we found. She has the lipo-a gene. That is the genetic gene, so that's like getting an additional LDL. They don't test for it, but everybody should get a test for it. And that lipo-a is at 95. She's in the yellow, okay? She also has an APOB of 94. Now, we would like to have her at least under 80. So she is at risk. She's at 94. And there's a lot of doctors that would see an APOB at 100 and give medications. Now, they may have a totally different lipid panel. Maybe they're looking at higher particle sizes. Now, she's really lucky because she doesn't have particle sizes. Her LDL particle sizes are not little teeny ones. They're big ones. So we want to have you under 467. She's got some big fluffy LDLs. So she's got big LDLs, and that means she's not going to have a lot of these particles, but she does have a gene marker. So on that APO bus, she's carrying these lipo-A's. She doesn't even know it until we tested her. So these lipo-A's are plaque forming, and a lot of people don't even know they have it. So this is an example. Her particle sizes are up a little bit, but it's in the yellow, not too bad. She doesn't have small ones. So when we look at this other information, maybe if we didn't get the APOB, we might say she's fine. But I look at this APOB at 94, and I'm not happy with that, because I know I want to get her at least under 80. And really, for her age, I would push for under 70. So what is she going to need to do? She's going to need to work on that Mediterranean diet. Now, she's better than my other fella, right? But her fats are anywhere from 35 to 40%. And typically, when I'm trying to lower some of the lipid panel, I try to get their fats between 25 and 30%. And then when I have somebody in big heap of trouble, I can drop their fats down to 15, sometimes even 10%, and put them on more of a plant-based diet, and I get results. Okay? Bottom line is getting results. So when we look, and it's not just about lowering fats. You have to balance your diet. And I talk about this in my course. When you get onto my website, we'll do a little plug for that, because it's important to know how to eat. Getting this information, I think, is great, because it gives you that little more nugget. But knowing how to balance these macronutrients in your diet is the key. It's not just that you're eating a Mediterranean diet. That drives me crazy when people say, well, just a Mediterranean diet. You got to work on the proteins, the fibers, the carbs, and the fat within the Mediterranean diet. So when we're looking at the type of diet we want to eat, it's going to be a lot of plants. We want the fiber, because it creates all these really good bacteria in the gut. It ferments, creates short-chain fatty acids, which travel to other areas of the body, decreases inflammation. But it's not just about eating a diet of all plants. You got to make sure you get enough protein, enough carbs, and in this video, the fats are what we're going to address. So let's try to give you something meaningful. I think of lipid toxicity, and right away I think of type 2 diabetes. Right away, I think of plaque in the arteries. So fat is good for you, and the right ones, I should say. Some fats, no matter how little, I don't think is good for you. So when we're looking at lipid toxicity, I'm talking about the excess. And really anything, what I have found in my practice is over 35% dietary fats. Now, there's some people that have no genetic markers. So our female, she had that lipo-a. Promise you, if she didn't have that gene, the lipo-a, her panel would have looked great. And she was on maybe 35 to 40% fats. So that would have been a case where she would have been fine. Let's go back and look. So if she didn't have this gene marker, she could be on a 35 to 40% diet, Mediterranean diet, probably be fine, because she didn't have other markers that were damaging. Her particle sizes of LDL were big, large ones. So, there's a good chance that probably would have worked out for her if she didn't have that lipo-a gene marker. But she does. So that means that we're going to have to drop her fats down just a little bit more, not a whole lot more. I find that I can go from 40%, if that's what she's eating, down to 25, and pretty much bring her lipid panel right back to where it needs to be. So I would want to decrease the lipid toxicity by decreasing body weight. Well, she's already at her ideal body weight, so we're going to really look to her diet. So I want to increase her fibers. I would definitely, as a dietitian, see how much dietary fiber she's eating and make sure that she's getting enough from these healthy sources, these lentils and beans and vegetables and all these foods that can help with the gut. But actually, these foods also help reduce the LDL cholesterols, because they have a type of fiber that's called a soluble fiber, traps those bad fats. That's exactly what fiber can do when you bring the right kinds of plants into your diet. Antioxidants, of course, I talked about this in my other videos, vitamin C, vitamin E, and these high color vegetables have natural antioxidants, and these antioxidants can neutralize the oxidation that goes on in the artery wall that causes all this plaque. Omega-3 fats, these are the good fats, highly recommend those. And niacin, because she's a lipo-a, can be of benefit. So let's go look at the fats and understand when I talk about having too much fat in your diet. Ideally, 25 to 35% is what I'm recommending as a registered dietitian. And why am I recommending that? Because I work with people that have type 2 diabetes and cardiovascular disease. And so if I'm not reducing these diseases for them, then I'm probably not going to have a job, right? So I've got to show that they're going to have improvement. And the way to do that is I do it through the diet. Sometimes if you've let it go too long, right, you're in your 60s or 65, sometimes I need to have medications and diet. But like with my other patient, he was on medications, having a low lipid panel, but wasn't on the right ratio of macronutrients. On the Mediterranean diet, but just not the right ratio. So let's look at how much fat we need. What's an easy way to do this? So fat grams are based on what you should weigh. So I'm just going to give you a range, a typical ideal body weight for a man, not what you weigh now, but think like, oh yeah, when I was in college, my ideal body weight was at 160 pounds, or maybe it was 165. What is that ideal body weight? And it's typically in the range for most men, anywhere from 150 to 220. That would be for a guy that's maybe 6'2", and this would be a guy that's, going to be maybe 5'4", 5'6". What we come up with is fat grams at the 25%, if I was really going to be conservative, for the APOB, would be anywhere from 50 grams if you weigh less to 75 grams if you weigh more. Now, I did say many people can be 25, even as much as 40% if they have no genetic issues, if they don't have any plaque. But I know as a dietitian, I'm going to keep them 25 to 35 because I just know from a lot of the work I do with patients that when I start getting over that 35% and they have some of these genetic markers, I'm starting getting those witching numbers, right? Don't want those. So on average, because I love just trying to give it to you simple, it's going to be in a range of 50 to 75 grams. And for the female, let's say ideal body weight is anywhere from 110, that might be somebody who's 5'2", to 165 pounds, maybe somebody who's 5'10". They're going to have a fat gram anywhere from 40 grams to 55, okay? So when I look, and that's at 25, I'm being conservative, assuming that they have an elevated APOB, which probably means they have some genetic markers in there, right? So I want to just give you an idea how quickly these fat grams can add up. 1 tablespoon of oil is 15 grams. 1 tablespoon of butter is 12 grams. 1 ounce of cheese is 9. 1 avocado is 20. 1 hamburger, 4 ounces is 17 grams. 1 serving of potato chips, which I think is only like 12 to 15 chips, is 11 grams. 1/4 cup of nuts, which is just a little handful of nuts, is going to be 15 grams. So I took a typical diet that somebody would consider healthy, that's going to be lower in carbs, right? But they're healthy. So this might have been what my first patient would have been eating. 2 servings of nuts, that's really only a half a cup. That's 30 grams. 1 avocado, 20. So you're already at 50 grams. 1 hamburger, it's 17. 2 tablespoons of olive oil. 3 ounces of cheese. It comes out to a total of 124 grams of fat. And most people, and by most standards, I did another chart, and let me show you. Oh, here it is. I put it on the same one. So the average female at 135 pounds, I just kind of took the middle of the road here and the middle of the road here. So I took the middle of the road for the average female, average male. So average female, 135 pounds, that's ideal body weight. 124 grams is 70% of her diet fat if she's eating for her ideal body weight. But she's probably not. She's probably overweight. And that's the key. She might, if she's eating like that, she's maybe a little diabetic. Maybe she's got 40 pounds of extra weight on her. So if you got 40 pounds of extra weight and you're eating all this fat, maybe then proportionate-wise, it's only 50% of your diet, or maybe it's only 45, which is why I don't calculate the percentage of fat you need based on what you weigh now. I do it on your ideal body weight because it's going to be more accurate. And why am I doing that? Because I'm trying to reduce the bad fats in your lipid panel. That's why I'm doing it, because I'm trying to get you healthier. So with this, is showing for this female, if I put her at 135 pounds, her average fat grams about 45 grams, which is probably, pretty in the middle here. And that's at 25%, which is going to be well fine, with the lipid panel, if it's elevated. And if she's actually doing this program here, which is the lower carb, probably low fiber there too, I'm assuming, she's at 70%. So that is, I think, super insightful, because it gives you an idea of how, number one, how important it is with these macronutrients. How much protein, how much fat, how much carbs, how much fiber. Whether it's a Mediterranean diet or a plant-based diet or a paleo diet, I don't really care. I mean, I care because there's healthy foods in those diets I would want you to have, right? I want to make sure that we're getting the macronutrients where they need to be, because it's those macronutrients that will really impact so many areas in your health, and particularly with the APOB. So I want to give a little plug. If you go to my website, myrnamethod.com, you can join my membership. And every Tuesday, I do a live stream just for members. And the only thing I do is talk about how to live your life at your leanest and healthiest. And obviously, healthiest is getting good set of labs, right? So the entire program is all about that. It's not about what we're doing on the YouTube, or where I'm just bringing in some useful information and having nutrition be applied to that. This is actually teaching you how to eat, balancing those macronutrients. So Sam, if you want to, let's go to the chat. Let's see if we have any questions. Oh, yes. Thank you so much. I'm so appreciative, because we did reach a milestone. We have over 500 subscribers. So thank you, thank you, thank you. I love it. It gets me super excited. It makes me want to work harder. So I appreciate that. And don't forget to like and subscribe. Yeah. Okay, awesome. So we will, oh wait, next week is Thanksgiving. Yes, it is. Okay, we probably won't have a stream. Yeah, we won't have a stream, but we'll start the following week for sure. Okay, guys, thank you. And we have one more marker to do, so we'll do it the following week after Thanksgiving. All right. Awesome. Thank you. See you.